Welcome back to Health Code Blueprint. Today we're continuing our journey through the ICD 10cm guidelines, now moving into Chapter 16, certain conditions originating in the perinatal period, covering codes P00 through P96. In this video, we'll walk through the essential rules that guide proper code assignment for newborns, including how to select the correct principal diagnosis, how to identify and code clinically significant conditions, and how to apply guidelines for bacterial sepsis and COVID-19 in the newborn. As always, this presentation is for educational purposes only. It's not legal, compliance, or billing advice. Make sure to follow official guidelines and your organization's policies when making coding decisions. Let's get started. Let's begin with the foundation, understanding the perinatal period. The perinatal period starts before birth and extends through day 28 of life. That part is fixed, it never changes. But here's the key distinction. Even though the time frame is limited, the codes are not. If a condition originated in the perinatal period, you continue to use the perinatal code for as long as the condition persists, even if the patient is now a child or an adult. So the rule is simple. If the condition began in the perinatal period, the perinatal code stays with the patient. This slide highlights one of the most important boundaries in obstetric and newborn coding. Maternal records and newborn records must never mix codes. On the maternal record, you never use Chapter 16 codes. On the newborn record, you never use Chapter 15 codes. And here's the Z38 rule. Z38 is used only on the newborn's birth record. It never appears on the mother's chart, and it's never used more than once. When a newborn is admitted for the birth episode, the principal diagnosis is always Z38. This code classifies the newborn by place of birth and type of delivery. A few important reminders. Z38 is assigned only once, at the birth hospital. If the newborn is transferred to another facility, the receiving hospital does not assign Z38. After the birth episode, Z38 is never used again. Think of Z38 as the newborn's entry point into the healthcare system. When you're coding newborn conditions, the very first question to ask yourself is this clinically significant? That's the guiding principle in perinatal coding. We assign codes for any condition that requires things like a clinical evaluation, diagnostic testing, therapeutic treatment, increased monitoring, a longer hospital stay. And here's something unique to newborn coding. If the provider documents that a condition may affect the baby's future healthcare needs, even if it isn't being treated right now, it still needs to be coded. That's different from adult coding, where future implications alone usually aren't enough. So the bottom line is, if it matters clinically, now or in the future, it belongs in the newborn's record. Sometimes documentation doesn't clearly state whether a newborn's condition is due to the birth process or acquired after birth. Here's the rule. If the provider documents the origin, code it as documented. If the provider does not specify, the default is due to the birth process, and you assign a Chapter 16 code. And remember, if the reason for the encounter is a perinatal condition, the Chapter 16 code is sequenced first. Z05 is used when a newborn is observed for a suspected condition that is later ruled out. Here's how to use it. Use Z05 when the newborn is evaluated for a suspected condition and, after study, the condition is found not to be present. Do not use Z05 if the newborn has signs or symptoms. In that case, you code the signs or symptoms instead. Sequencing rules. On the birth record, Z05 is a secondary code after Z38. On a readmission, Z05 can be the principal diagnosis. For prematurity and low birth weight, coding is based strictly on documentation. You must have the recorded birth weight and the documented gestational age, no assumptions, no estimates. And here's something many coders miss. Category P07 can also be used later in life if the patient's prematurity or low birth weight continues to affect their current health status. When you're coding newborn sepsis, there's an important default rule to keep in mind. Unless the provider clearly states otherwise, you assume the sepsis is congenital. That's the starting point for all P36 coding. The structure itself is pretty straightforward. You begin with P36, which captures the newborn sepsis. If the organism isn't already built into that P36 code, you add a B96 code to identify the specific bacteria. And if the documentation shows severe sepsis, you also assign R65.2, along with any organ dysfunction codes that apply. One last reminder. If the P36 code already names the organism, you don't add B95 or B96. In that case, the organism is already accounted for. When it comes to COVID-19 in newborns, there are a few specific rules you need to follow. If the newborn tests positive and the provider doesn't specify how the infection was acquired, you'll assign U07.1, along with any codes for the documented manifestations. In other words, you treat it as COVID-19 in the newborn, but without assuming the source. However, if the provider clearly documents that the infection was acquired in utero or during the birth process, then you shift to congenital coding. In that case, you assign P35.8 for congenital viral disease, and you still add U07.1 to capture COVID-19 specifically. And one last reminder. Even when COVID-19 is present, Z38 remains the principal diagnosis on the birth episode. That rule never changes. Now let's talk about P95, which is the code for stillbirth. This is one of the most tightly controlled codes in Chapter 16, and it's only used in very specific situations. P95 is assigned only in facilities that maintain a separate stillbirth record. If your facility doesn't have that structure in place, then this code isn't used at all. It's also an exclusive code, meaning no additional diagnosis codes are ever reported with it. P95 stands completely on its own. And one more important reminder, P95 is never used on the mother's record. It applies only to the stillbirth record itself. So the takeaway here is simple, P95 is a standalone code, used only when the facility's documentation system supports a dedicated stillbirth record. Alright, let's wrap everything up with a quick operational summary. These are the core rules that will keep your perinatal coding accurate and consistent. On the always do side, always sequence Chapter 16 codes first when a perinatal condition is the reason for the encounter. When the documentation doesn't clearly state whether a condition is due to the birth process or acquired after birth, the default is the birth process, so you assign a Chapter 16 code. When both birth weight and gestational age are coded, birth weight is sequenced first. And remember, Z38 is used only once, and only on the newborn's birth record. On the never, don't side, never assign Chapter 16 codes on the maternal record. Never assign Chapter 15 codes on the newborn record. Never use Z38 at a receiving hospital if the newborn was transferred, it belongs only to the birth facility. And never use Z05 if the newborn has signs or symptoms. In those cases, you code the symptoms or the confirmed condition instead. Following these rules helps ensure accuracy, consistency, and compliance across all newborn encounters. Thank you for watching this episode of Health Code Blueprint. I hope this walkthrough of Chapter 16 helps you feel more confident navigating perinatal coding scenarios and applying these guidelines in real-world cases. I appreciate you spending this time learning with me, and I'll see you in our next episode.